Very good day to all present. I bring greetings from India. I am Dr. Ankush Garg. I'm working as a senior resident in the Department of Anesthesia and Intensive Care at VMMC and Safdarjung Hospital. And along with the guidance of my professor, Dr. Shruti Jain, I will be talking about a rare case of food botulism with bilateral dilated and fixed pupils, along with idiopathic intracranial hypertension. Foodborne botulism is considered an uncommon clinical condition in India, and it is caused by the accidental exposure to botulinum toxin produced by Clostridium botulinum bacteria, which is an anaerobic spore-forming bacteria. It is a gram-positive rod, an obligate anaerobe, and is ubiquitously present in our environment. The disease manifests itself as a clinical syndrome of symmetrical cranial nerve palsies, followed by descending symmetric flaccid paralysis of voluntary muscles, may also lead to involvement of the respiratory muscles. So clinical suspicion in sporadic cases presenting late with neurological symptoms is of utmost importance to identify these cases. I will begin my case report. A 22-year-old lady started having pain in the abdomen associated with cramps early in the morning around 5 a.m., for which she presented to a hospital outside, near her home. Gradually, she developed blurring of vision, followed by drooping of the eyelids, and a change in the voice was noticed by the attendants within a few hours. There was weakness in the upper limbs, followed by lower limbs, and shortness of breath, for which she was intubated and started on mechanical ventilation. Upon no improvement in clinical condition over the next 2 days, she was referred to our institute for further management. In the ER of our hospital on presentation, the patient was sedated and paralyzed on volume control mode of mechanical ventilation. A temperature at presentation was 98.6 degree Fahrenheit with a heart rate of 55 beats per minute, a blood pressure of 158 by 72 millimeters of mercury, and a saturation of 100% on 40% FiO2. A quick short history was taken and a primary survey was done, which revealed fixed dilated pupils, and all the other systems appeared to be normal. On further investigation, a point of care ultrasound revealed an optic nerve sheet diameter was performed, which was 7 millimeters in both the eyes, which suggested a raised intracranial pressure. This was confirmed by doing an ophthalmological examination, which revealed an impending papilledema, which confirmed raised intracranial pressure. The NCCT head was done, which revealed a normal study. So the mannitol was started in the ER and the patient was shifted to the ICU for further management. In the ICU, the patient gradually regained consciousness and became oriented with a normal mentation. A detailed examination was performed and previous findings were confirmed. Ptosis was observed along with external ophthalmoplegia, and a hyperreflexia was present with decreased power. Upper limbs had a 3/5 power bilaterally and lower limbs had a 2/5 power bilaterally. Sensory system seemed to be completely intact. Some special investigations were performed. Nerve conduction studies were suggestive of polyradiculopathy. Rapid nerve stimulation tests was normal. The cerebrospinal fluid studies showed a raised opening pressure with normal fluid composition. ISPAC test was negative and the acetylcholine levels were normal. And there was no evidence of sickling on peripheral smear. In the ICU, a detailed history revealed ingestion of home canned peas the night before the onset of symptoms, which may be the culprit for the food botulism. Botulism antitoxin was not administered due to unavailability of the toxin and a delayed presentation of more than 72 hours after the symptom onset to our institute. The patient's symptoms resolved after 8 days of supportive treatment in the ICU, and the patient was sent to the ward to be discharged. So botulism is caused by a neurotoxin produced by the sporogenic Clostridium botulinum. 7 types of toxins have been identified based on the amino acid composition, which have been named from type A to type G. Type A is most commonly seen in the European continent and is one of the most severe forms of the disease, which requires mechanical ventilation and is associated with a high mortality. Type B and type E present with GI symptoms, the gastrointestinal symptoms such as nausea and vomiting, abdominal pain, diarrhea, xerostomia, followed by a neurological symptoms. All the forms of botulism They present in a similar fashion. Foodborne botulism, wound botulism, infant botulism, inhalational nitrogen botulism, all present in a similar format. So clinical symptoms occur owing to the inhibition of acetylcholine release and appear after incubation period, which may be from hours to days. Therefore, a history of food consumed at least 2 days prior to the beginning of symptoms is of utmost importance to identify the source of infection. Most cases are due to ingestion of preserved tinned food, home canned food, spoiled meat, and fish. Inhibition of acetylcholine at the peripheral cholinergic synapse leads to transient muscle paralysis, while the involvement of the sympathetic and parasympathetic innervation to the iris leads to the fixed dilated pupils, as was seen in our case. Early ophthalmologic signs include accommodative paresis, blurred vision, frank diplopia due to paralysis of cranial nerves 3, 4, and 6. Severity of ophthalmoparesis has been associated as an indicator of overall severity and progression of disease. Idiopathic intracranial hypertension, or IIH, is a condition of raised intracranial pressure of unknown cause. It is frequently associated with sixth nerve of the abductive nerve palsy, which presents as a false localizing sign for IIH. Foodborne botulism was suspected based on the typical presentation of symmetric cranial nerve palsies manifesting as diplopia, blurred vision, ptosis, dysarthria, dysphagia, descending symmetrical muscle paralysis, and respiratory muscle paralysis. IIH with external ophthalmoplegia due to the cranial nerve 6 palsy helped us suspect botulism. A differential diagnosis of impaired neuromuscular transmission such as Guillain-Barré syndrome, Miller-Fisher variant, myasthenia gravis, and stroke were also considered. GBS, or the Guillain-Barré syndrome, usually starts with a sensory complaint, areflexia, and an ascending type of neuropathy, whereas botulism shows a descending neuropathy. The Miller-Fisher variant has oculomotor dysfunction associated with cranial neuropathy and ataxia. Myasthenia gravis lacks autoimmune symptoms. Electromyography pattern helps in distinguishing the cause, and a negative ISPAC test rules out myasthenia gravis. And Lambert-Eaton syndrome is rarely fulminant and is associated with small cell lung carcinomas. Stroke was excluded by clinical evaluation and a normal NCCT finding. The CSF studies ruled out any infective causes. Medical treatment of botulism is essentially supportive. Antitoxin should be administered as soon as diagnosis is suspected, as it only acts before toxin is irreversibly bound to the presynaptic membrane. Recovery is seen by formation of new axon terminals. So I conclude, although the progression of paralysis in patients of botulism is unique and recognizable, but often due to late presentation to the hospital, the symptoms are misdiagnosed. Since we received the patient at day 3 from the clinical onset of symptoms, botulinum antitoxin, which is the only specific treatment therapy, could not be administered. Keeping a clinical suspicion about botulism in patients presenting late with the neurological symptoms helps in avoiding a misdiagnosis. Here, an increased ICP leading to cranial nerve 3, 4, and 6 involvement helped us suspect botulism as the culprit. History taking is an important part of the medical field, but cases like these have emphasized more on this fact. These were my references. Thank you so much for your time.